there's any extraneous circumstances, acute stressors that may be involved here. I didn't sleep well last night. I knew I was coming here. That is kind of an extraneous situation. That is part of insomnia. I mean, that these are important things that need to be asked. Some stressors can be there chronically. Patients have chronic anxiety disorders. A good psychiatric history is really pivotal. There's a very clear link between depression and insomnia. They can really feed on each other, and one can make the other worse. So that is essential. Doing a good sleep history to see if there's other sleep-related disorders. We mentioned before sleep apnea. Doing a good sleep history and doing a scoring system to see how much excessive daytime sleepiness these patients have, to see if you need to do any further testing, like a sleep study. Now, we don't necessarily have to do sleep studies. They don't have to be done on these patients. But if there is a suggestion of obstructive sleep apnea, for example, or central apnea, or limb movement disorders, or where patients have inadvertent movement of their extremities that causes arousals, that requires a sleep study, for example. So it's very important, and all of this is part of that history that I was alluding to earlier.
Thank you. You also talked about the need to do a detailed, as part of this initial diagnostic evaluation, the need to do a detailed pharmaceutical history.
That's correct.
And what does that mean?
Pharmaceutical history is medications, and these can be prescribed medications or just things that you may not even know you're taking. I mean, sometimes I've had patients that just we're taking these pills for migraines, and pills for migraines often contain caffeine, Excedrin, migraine, for example, and they didn't realize that their migraine pill was what was causing them to not sleep. So it's really important to rule out and exclude medications both over the counter, but as well as prescribed, but also illicit drugs and things like methamphetamines, or patients that have substance abuse issues where they may be withdrawing from something, and that is resulting in their insomnia is also important. So I think a very detailed pharmaceutical history, including illicit substances, needs to be asked about and ruled out.
You also mentioned a detailed physical examination, again, as part of this initial diagnostic evaluation for insomnia. What would that detailed physical examination need to include?
Right. Virtually any medical condition, certainly chronic medical diseases, can lead to insomnia. I mean, these are things that we all know about, conditions like asthma. Under my own specialty, patients with asthma have nocturnal awakenings when they have difficulty breathing. They have wheezing at night. So if you don't control their asthma, you don't control their insomnia. So there are a whole host of medical problems that sometimes just a physical exam, examining the patient, can help you at least have a clue and detect and be able to move on further with further tests and confirm. Congestive heart failure, patients with bad heart failure, they can't sleep flat at nights, and their insomnia is because they can't breathe at nights. Patients with diabetes, whose diabetes is very poorly controlled, they urinate multiple times at night. That is the problem. Patients with bladder problems, or just enlargement of the prostate that we just see as part of aging in men, can cause frequency, meaning urinating multiple times, and that could be the cause. So the history, the physical exam really kind of adds to the history and tries to pick up potentially some conditions that may be obvious. Thyroid disorders like low and high thyroid conditions, hypo and hyperthyroidism, sometimes you can get a clue to that as the exam that you do and feeling the thyroid. But certainly a lot of what we find on physical exam needs to further be confirmed by testing, like blood testing and other testing to confirm.
And you did mention in your report the requirement or the need to do laboratory testing or blood testing to kind of rule out some of these other factors.
Right. Basic, this is for the initial evaluation, just basic testing, just ruling out basic conditions, making sure their kidney function is normal, making sure that they don't have diabetes, checking for the blood test we use to check for control of blood sugars over an extended period of time, called the hemoglobin A1C, can sometimes be reasonable. Certain conditions, such as restless leg syndrome, for example, can be associated with low iron stores, so we check ferritin levels in these patients. So there are a number of these tests that are routine that can at least clue us into these reversible processes where the treatment is really treating the underlying condition first and then seeing if the insomnia gets better.
And of course, appropriate blood work or laboratory work would also reveal narcotics or things that are in the blood as well, correct?
That is if you choose to look for that. I mean, normally I think you do a good history and you ask your patients, the hope is that they would divulge that information to you.
And if you had, as a doctor, if you had suspicions or knowledge and you felt the patient was not being candid, you could do that blood work or simply refuse treatment, correct?
Absolutely. I would argue that, my perspective is I would not want to do a test that my patient is not aware of. Sometimes I have to admit that people do urine tests on patients for basic drug screens when they come in very sick into the emergency room. But in general, for someone like this, I personally would not advocate doing a test without my patients knowing about, and if I feel that the patient isn't divulging that information, then absolutely, I would not want to move further and treat them medically without, knowing that they are not perhaps sharing all the information that needs to be shared, therefore impeding my ability to really help them and implement the appropriate therapy.
And so if you felt, again, to be clear, if you felt you were not getting the information desired from the patient, you could simply refuse to treat that patient.
Absolutely.
Now, in doing this diagnostic evaluation, you mentioned if you do find some underlying condition, either a medical condition or psychiatric or substance abuse, the next step then would be to treat that underlying condition with the appropriate therapy as you proceed through this insomnia care. Is that accurate?
That's correct.
And so what is the aim there as far as the therapy?
Well, the therapy is really to deal with the underlying problem. I mentioned some examples of medical conditions. I mean, if you treat the underlying medical problem, and if it's that problem that is resulting in the insomnia, I used asthma as an example. Patients waking up in the middle of the night because they're wheezing. You gain better control of their asthma, their insomnia is going to get better. If you treat their underlying, let's say they have anxiety and depression, you treat their anxiety disorder and their depression with antidepressants, for example, that can control their insomnia. So these are treatments really that are geared towards secondary insomnia, where the problem is due to an underlying medical, psychiatric, etc. History. And the other thing is if it's an environmental cause, they're just sleeping in the wrong place. They got their kids sleeping in the bed with them, and they're kicking them all night. I mean, of course, you have to change the environment. So it's important to be cognizant of those factors as well.
Now, in this first phase of the appropriate treatment for insomnia, the need to conduct a diagnostic evaluation, you found that Dr. Murray acted with an extreme deviation or gross negligence regarding the standard of care.
Yeah, again, it's imperative when you're starting treatment on somebody, and this goes for any condition, is to start off with a detailed history. And to treat insomnia really without ruling out secondary causes, to really saying, well, what is the root of the problem, and dealing with the root problem is key before actually starting to just medicate patients.
And you noted in your analysis that Dr. Murray admitted knowledge that Michael Jackson was seeing other doctors and seeing IV sites on his body.
Right.
Okay. Yet he did nothing to ascertain the other care.
Right. I think it's really key when you are suspicious of that, and obviously, I think what you're alluding to is being suspicion about someone having a substance abuse problem. It is really important to really hone in on that and try to get more history. And if the patient doesn't provide that history, it is imperative on the physician to try to get as much possible. And then finally, we mentioned earlier, if they're not really, able to do that or willing to do that, it is to refuse care in terms of just providing with pharmacological medication therapy.
And you described that need to either make independent inquiries about the care by other doctors or simply to refuse treatment. To not take one of those options is an ethical failure on the part of Dr. Murray.
Correct. I mean, this is really, again, patients come first, and it's our duty to try to find out as much as we can, to make every effort to try to get as much history. If a patient comes in and we're not able to talk to them, and we know they were hospitalized somewhere else, what we first do is try to get every single record from wherever they were hospitalized, to get every detail. And I think it is really to ignore the patient's past and their history that is so pertinent to what you're doing and how you're managing them is really unethical.
So in your analysis then, by bypassing the diagnostic evaluation and bypassing whether there's some secondary cause of the insomnia and going straight to the infusion of these dangerous sedatives, was that part of your conclusion that this was an extreme and unethical violation of the standard of care?
That's correct. That's correct. Because obviously there was a great potential here for there to have been these reversible causes, these secondary causes to the insomnia. I'm still not saying that the management, even if this was a primary insomnia, was appropriate, but I'm saying that there were clearly signs that there were secondary causes, whether it was substance abuse issues or anxiety issues, underlying psychiatric issues, psychological problems. Those issues needed to be addressed first and foremost with really great care and attention, and not just proceeding to medical management with drugs.
And once a determination was made through this diagnostic evaluation that there was either, let's say, a secondary insomnia or a primary insomnia, you've indicated there are two, well, it's a multifaceted approach in treatment that can involve both pharmacological approach as well as a behavioral approach. Can you explain what you mean by that?
Right. Very often, obviously, once you've done your initial workup, one of the most effective ways to treat insomnia, both primary as well as the secondary causes of insomnia, is just what we call cognitive behavioral therapy. And it really incorporates many factors. Patients that have primary insomnia, particularly over a prolonged period of time, have this fear of going to sleep because they just feel like they associate the bed and that situation with deep anxiety because they just can't do it, and it becomes this huge fear. So there's a lot of behavioral cognitive techniques that deal with that underlying fear, that really try to make sense of that for the patient, allow them to be calm. But that is also, in addition to that, there are these various additive things that are all helpful once used in combination. Things like sleep hygiene, just very simple reminders like the fact that you shouldn't be taking caffeinated beverages anytime within at least 4 or 5 hours before going to bed. At least, I would say probably 6 or more for people that have problems. Alcoholic beverages, to avoid alcohol, people always